Assalamualaikum warahmatullahi wabarakatuh and good morning. Thank you for joining us at Breakfast at UMHealth, episode 13. I'm Marzida from the Department of Anaesthesiology, and I'll be chairing the first half of today's session. Communication skills is a crucial but somehow is a neglected facet in academic curriculum. Today, we are going to have a webinar on effective communication and speaking up, essential skills in healthcare. And it is going to be delivered by Professor Rafidah Atan, who is a consultant intensivist in the Department of Anaesthesiology. She holds a European diploma in intensive care and a PhD from Monash University. She is also our coordinator for the UMMP program, and she has a special interest in simulation and non-technical skills in anesthesia. So being an intensivist and dealing with people from different disciplines, she is, of course, equipped to give this lecture. So without further ado, please welcome Professor Rafidah.
Bismillahirrahmanirrahim. Assalamualaikum and good morning, everyone. Thank you so much, Prof. Marzida, for that kind introduction. So I'm going to share my slides so that we can start. Okay. So I must say that this is a topic that is close to my heart. I spent many years teaching medical students how to speak up, and this topic ties very closely with my other passion, which is patient safety education. So basically, these are my objectives for today. My objectives for everyone is to maybe share tips on how to speak up. I'm going to talk mainly in terms of crisis situation or patient safety indications, but you can use the same skills for raising issues during a committee meeting as well. And also maybe share some tips on mental preparation for backlashes, if any. And to the leaders in the audience, basically my objective is to highlight to you why it's important to encourage speaking up among your team members. I would like to highlight behaviors that affect the speaking up culture, whether you are actually enabling or we are actually becoming a barrier to speaking up. And, to make you consider teaching your team members some speaking up skills. And I'm going to start by sharing how I teach people how to speak up. So maybe just to jog your memory a little bit, I want you to recall and reflect, all right? So maybe those of you who are very senior, already you might not have trouble speaking up now, but maybe recall back to the time when earlier in your career. And those of you in the audience who do still have these issues, I just want you to think about whether you've ever felt that you wanted to say something because you thought usually someone above you in rank, had made a mistake or had missed something, or you simply disagree with them, but you are unsure or uncomfortable to do so. So ask yourself, how would the above situation usually end? And I want you to rate yourself from 0%, meaning you would never say something, to 100%, where you would always say something. What was your personal rate of speaking up? So just a few seconds to take stock of that. So how is speaking up different from simply communicating? So I'm going to quote Dr. Gandhi from IHI for this. So speaking up requires deliberation and usually a degree of courage. That courage takes different forms, whether it's a patient questioning the need for a test, a nurse flagging a medication contraindication, or a safety manager bringing below benchmark data to a leader's attention. Now, we all face this to a certain extent. People face a challenge of speaking up at all levels, okay, because there's almost always someone above you in the rank. And sometimes we need to speak up, or the more correct term is speak out when we deal with our peers as well. So when we constantly observe intimidating or bullying or unprofessional behavior that we want to raise that they might not realize, or where we're concerned about certain aspects of practice which we think might not be evidence-based. And so that's a form of speaking up and speaking out as well. In our local scenario, somehow I get a sense that we do sort of maintain hierarchy, right? So we have a steep authority gradient, seniors to juniors, specialists to non-specialists, teacher to student, doctor to patient. Culturally, it is often perceived to be disrespectful to correct your elders, superiors, or teachers, or to disagree, even if they're nice about it. And there's certainly this fear of damaging relationships. So this is just to quote Dr. Chris Nixon from lifeinthefastlane.com, right? So you need to recognize when speaking up counts. So speaking up refers to raising a concern before an act, all right, rather than after. So if you raise it only after the act has occurred, it doesn't count enough as speaking up. So that's more like, speaking out or whistleblowing. Yeah, speaking up is vital to maintaining patient safety in critical care settings. In fact, in any settings, right? Yet often doesn't occur. We need to remember that we must always advocate for our patients and never leave a situation thinking that I should have said something. So in fact, when I face this issue, but I'm not sure whether I should say or not, I emphasize that I have a greater fear of leaving thinking I should have said something rather than, so that should overcome my fear of actually saying something. Patients should also be encouraged to speak up. Speaking up requires not only courage, but also skill, and is essential. And I feel that first, do not be silent is akin to first, do no harm. There are many studies that have been looking at the issue of speaking up across social and contextual factors. So the ones I've displayed showing papers from the United Arab Emirates, Hong Kong, Malaysia, Japan, in fact, in the Western world as well. And it's a big problem, okay? In fact, it's recognized that people will only choose to speak up when they have concerns. We could prevent a lot of adverse events and could keep a lot more patients safe. Silence truly kills, yeah? So, when we are among the seniors, all right, so we need to take stock of where we are as a team, all right? So what we should be aiming for as a team is that this is the gold standard. The gold standard is that all team members across all ranks feel comfortable to have an open and respectful communication about anything, basically. They can raise issues about safety rules violation, potential mistakes, each other's fallibilities, and, until we reach that, we have not reached the gold standard. These are just some of the barriers that people have identified to, why people don't speak up. And of course, it's intuitive to us as well, because these are the very things that have stopped us from speaking up at some point in our career. So fear of getting someone else in trouble, fear of conflict, you don't want to be seen like you're not a team player. When we don't have an anonymous mechanism to raise important issues, it's important to have that. The feeling that nothing would change, right? So even if we're nice about it, if people raise issues with us and we don't do anything, after all, people just don't bother to raise issues, right? Not a priority, we think we're too busy, okay? So fear of poor personal evaluation if it's a supervisor-supervisee relationship, and not an expectation in my clinical area. So that is sort of suggestive of a cultural issue. So the culture is that you're not expected to speak up when you say something that's not right. Okay. We also need to recognize enablers so that we can replicate or adopt these behaviors as much as we can. Facilitators include evidence that speaking out results in meaningful change. Again, when there's an anonymous mechanism for reporting, especially when it's a very serious issue, leadership showing commitment that we value team members, putting forward their opinions and speaking up and looking out for each other, greater protection from retaliation, recognition of exemplary conduct, and communication skills training. So we do need to train people how to speak up. What they found was that they get faster and higher quality challenge when people are taught how to speak up. Okay, so a specific teaching session, all right, or debriefing intervention, all right. So this tend to improve the ability of team members to speak up. And they also find, of course, we found that as well in the course of us going through our career. As we get more senior, we get more comfortable in speaking up. All right, so this emotional maturity, all right, helps. So the thing about emotional maturity, what have they observed? They observe not just the speed of challenge increase, but also the quality of challenge. All right, so there's a question that, perhaps if we train our junior doctors and our medical students and junior staff members, that we can fast track this. Okay, so how does it manifest its emotional maturity? They're able to weigh up, the decision to speak up better. They can search for better, more elegant ways to convince the other party of their concerns. This includes the use of non-verbal cues or actions. Now, in terms of learning to speak up, they also found that often it says that, something like giving people the appropriate words or the phrasing, right, can help them speak up, because not knowing how to phrase it inhibits the ability to challenge a decision when the patient safety concern arises. Okay. And however, the skill set required to challenge authority is often not specifically taught in educational curriculums. So I'm going to start off by sharing with you how I teach communication styles. And I must thank my ex-colleagues from Monash University, Australia, for teaching me how to teach this, all right? So basically, there are 4 communication styles, and we can also reflect on our personal communication style, whatever level you are. So there's assertive, there's aggressive, there's supportive, and there's submissive. Yeah. So what is assertive? Okay. Assertive communication style is when you say something, you focus on your own needs, but you do it in a way that you don't put the other person down, right? So that's assertive. As opposed to aggressive is that you are focusing on your needs, right? But you do it in a way that you put down the person you're speaking to. So just to give a simple example, let's say you are a registrar or a consultant, you walk past and then you see a patient with abnormal ECG trace on the cardiac monitor, but no one's done a 12-day ECG. So to say that in an assertive way is to say, the ECG trace on the monitor looks abnormal, we should do a 12-day ECG now. So yeah, an aggressive way of saying the same thing is, the patient's ECG trace on the monitor looks abnormal. Why hasn't anyone done the 12-day ECG? All right, so that is in a way communicating the same need, but putting it in an aggressive tone. So I'm not saying that because you're assertive, you can't say your concern or, that why was it not done in a timely manner. After the ECG is done, maybe an assertive way to say is that, okay, we need to debrief about that. So I need to know why it seemed that we took some time to do the 12-day ECG. So it's just saying in a way that doesn't put the other person down. Okay, now supportive is when we focus on other people's needs and we do it in a way that we don't put ourselves down, all right? While being submissive is when we focus on other people's need and we are putting ourselves down either in our thoughts or in our words, all right? So let's say you're a houseman or intern who has just reported for duty. During a crisis, you know that the patient's SpO2 has dropped to 90%, but no one's taking action and you're not sure whether people notice or not. A concern has highlighted this to you. Being supportive is that knowing that you're very new and you're not sure, you can just move forward and say, doctor, the patient is desaturating. Is there something I can do to help? All right, that's supportive. Being submissive is an example of response is they probably know what they're doing. There must be a reason for that. I'm new here and I will not interfere. My opinion doesn't matter, right? So it's a submissive way of communicating and thinking, right? So we should always train ourselves or choose to be assertive and supportive. And this is how professionals should communicate at all time. And this is best for effective teamwork and communication. And we need to avoid being aggressive and submissive because then being aggressive is not in line with best professional behavior and it will undermine teamwork and communication and will shut down communication often. Patient safety will be compromised because we are making the environment unsafe for people to just say what they're thinking, their concerns are, what issues they're facing. And do remember, okay, when we see people behaving aggressively all the time, by behaving submissive to them, we are feeding the aggressive behavior. So that's like more likely to continue. Yeah. Now, if this is difficult for you, you can do it in stages. And the studies that show that you need to teach people how to speak up, sometimes just giving them some scripts, all right, that would help them. Okay, so this is what we call graded assertiveness, all right? Graded assertiveness meaning you can start at a lower level and then go up and up and up with increasing levels of concern. So the acronym is PACE, yeah, okay. So P stands for probe, A for alert, C for challenge, E for escalate. So when you probe, you're just making a statement or an observation. So let's say the patient's blood pressure is 85/40, a lot of chaos, someone's looking at the monitor. This junior doctor is not sure whether that's the, people notice it or not. We just say the patient's blood pressure is 85/40. All right, so just a statement. If it's an oversight, sometimes this is enough. So let's say, no one's taking action, you're not sure whether you're hurt or, and you want to escalate it to the next level. You can go to the next level, which is alert. You can say, doctor, are you aware that the patient's blood pressure is 85/40? All right, so that's more direct inquiry, unlikely to be missed or not heard, right? Or provide an alternative. Doctor, the patient's BP is 85/40, shall we increase the vasopressors, right? So that's the next step. The third level, all right, is a good way to start sometimes all the time, which is to pose it as a curiosity, all right? The patient's BP is 85/40. Is there a reason we are not increasing the vasopressors? Okay, so because there are situations where people want to be judicious with the vasopressors and all that. I'm not going to go into that, but so posing it as a curiosity is highlighting a concern and checking, whether you're correct or not at the same time. And E is escalate. When the situation is really dire, the patient's safety is really compromised, then they need to check with another authority. If that, it is a judgment thing, or you can announce to the team, since everybody seems to be fixated or something else. Doctor, I'm going to increase the vasopressors now. All right. So by so that's escalate, right? So I'm going to give another scenario just to drive the point home further, right? So let's say during ICU rounds, there was an intense discussion between the ICU consultants regarding a patient's direction of care. You would note that the SpO2 has gradually dropped to 85%. The ICU MO appeared to be looking at the monitor, but is not taking any actions. He and she then went off to answer a phone call. What would you say? All right. So for P, you could just make a statement, right? The patient saturation is 85%. All right, so if it's an oversight, something that's enough for people to take action. They didn't hear you because they're fixated on something else, or you're not sure. You can go up to the next level to say, excuse me, doctor, are you aware that the saturation is 85%? Or provide an alternative, just to say the saturation is 85%. Shall we increase the oxygen concentration, right? To pose it as a curiosity, right? You could say, doctor, why are we not concerned that the patient saturation is 85%, right? Okay, and escalate, of course, the same thing, grab the attention of another senior or announce the saturation is 85%, I'm increasing the oxygen concentration now. Now, the examples I've given are in relation to a safety concern and maybe targeted to more junior members of the audience, but you can do the same thing with raising any concern. Basically, I do this if I want to, raise concerns during committee meetings or, department meetings or something like that as well. So just remember some words of caution. You don't always have to start at P and then go to A and go to C and then E, all right? If it's an oversight, usually P and A is enough for people to take action. If you're very timid, don't get stuck at P, all right? You need to, because some people just keep announcing saturation 85%, excuse me, doctor, saturation 82%, saturation 80%, saturation 75%, right? So that's being stuck at P. You do need to escalate if you find that there is no action being taken. What you need to realize that fixation errors, where people actually want to take action, but they're so fixated on something else that they totally miss something that is of dire circumstances, is a real threat to everybody, all right? Especially in emergency situations. So you do need to escalate and highlight your concern. Don't choose E if you tend to behave in an aggressive manner. Don't choose E as a standard approach all the time because that's not going to all go well with teamwork and communication as well. And curiosity is a good standard approach in many instances. So I teach my students to actually pose concerns as a curiosity if they really feel unsure, right? So examples of curiosity is saying, doctor, I know that PCO2 is 65 and we're still planning to extubate this patient. In what clinical situation is this appropriate? All right. So that's one way of posing, highlighting a concern as a curiosity. Another example is, someone asking, doctor, I note that the patient's potassium level is 5.8. I'm curious as to why we're not arranging to commence dialysis now. All right. So there's just some scripts we can share with our junior members. So remember, it is not disrespectful to speak up. We need to remember that it's not about who is right, it is about what is right for the patient, right? And the patient should always be the focus of our actions. Right? If people get upset at us for trying to raise a safety concern, the problem really is with them, not us. So we do need to have that sort of mental strength to deal with any backlashes. And sometimes people are just having a bad day, so they may lash back or something like that. But honestly, they actually would be thankful to you for raising a concern. Okay. Now, other approaches to speaking up. All right. So this is from the Center of Medical Simulation. We use this during debriefing. It's advocacy inquiry. So maybe this is more for senior members of the audience, right? You want to raise concern, but you don't want to make it sound like it's scolding or shutting down communication. Other people can use it as well. So it's called advocacy inquiry. The acronym is ACE, A, C, and E. So advocacy, just saying what you saw. I know that you did A. Concern, just saying what your concern is. My concern is that if you did A, then B will happen. E is inquiry. I'm curious as why you made that decision. All right. So one example of a script. I know that we're planning to extubate this patient with a CO2 of 65. My concern is that I thought that this meant the patient wasn't ready for extubation, and I'm curious as to whether this is appropriate. All right, so that's an example of a script that we could always use. These are just some examples. So do education interventions work? They found that majority who have tried this found that there's increased probability of challenging authority. Multidisciplinary causes is a popular way to do this. What are the remaining barriers? Okay, when it's coupled with uncertainty. So that's why raising your concern as a curiosity is a good way to balance this out, right? So these education interventions, by teaching them how to say even when they're uncertain, ensures the ability to speak up even people feel unsure whether they are correct or not. So assertiveness communication training programs and found some degree of effectiveness with all target groups. Interns, residents, registered nurses, nursing students, right? So they seem to work, yeah. And you can't fix problems you didn't know you had. So can we measure our speaking up culture? So apparently there are questionnaires for this. Okay, you can measure your speaking up climate for patient safety and for professionalism. So they find there's an even greater reluctance to speak up when it's about professional behavior, right, across all ranks, right? So perhaps we should measure this and use it to track our team's progress. Now, if we are among the senior members of the team, this is what we need to do to encourage speaking up, all right? We need to be a safe person for someone to raise issues with, and this is a major contribution from you. Now, safety is not what you claim. Safety is what people feel. If people constantly don't bring issues to your attention, then you're not safe, regardless of you saying, I'm safe, all right? Okay, so that's just for self-awareness. We need to create an environment where there's psychological safety to speak up, and so we need to role model it. We need to, maybe pull people aside. We find they're behaving unsafe, all right? Okay, unsafe to speak up to. We need to train our members how to speak up. Perhaps institution-specific policy and escalation pathways, right? Sometimes I get, my nurses come to me. I try to stop that doctor from, maybe because this doctor from that team might not be clear about our policy in ICU. So they might do something that's against what our policy is. So if they try to stop and then they're ignored, so I actually tell that you need to escalate. So you can either escalate to me, or you go up to your team leader, or to your sister, or to your matron. You need to escalate, all right? Okay, so making clear the escalation pathways, and that they be safe if they escalate, right? Realize that not taking action when issues are raised, brought to your attention, actually stops people from highlighting issues. So that's also a behavior that goes against encouraging speaking up. Now, when we have been spoken up to, regardless of our rank, you need to reflect. How did I respond to that? Is my response likely to encourage further speaking up? Or did my verbal and non-verbal response communicate, don't ever try that again? So we must try to develop self-awareness in this method. So finally, remember this. If it's important to clarify, just ask that silly question. It's really okay, you're doing the right thing, right? Now, when I deal with inappropriate responses to my raising appropriate concerns, I tell myself, it's not about me, it's not about you, it's about the patient. I need to say this because I don't want to leave this situation. Something bad has happened and I wish I said something, all right? Look, I don't always get this right either, but I continue to try to improve myself, and I'm sure you all are trying your best as well. So thank you, everyone, for your kind attention. And with that, I end my talk. We can't hear you, Prof. Sorry.
Thank you very much, Prof. Rafidah, for that very interesting and useful tips of how to deal with difficult situation by using our communication skills, and also when we are trying to save patients' lives. We have a couple of minutes for question and answer session. This is the first question come from Professor Lo Pui San. Communication can be very complicated. What happens if the receiver of a message takes it the wrong way? For example, a patient may listen and say understand at the moment, but complains later that it was condescending.
Okay. So my personal opinion about this is that communication is not what we give, is what the other person receives. So for example, in ICU as well, because often there are many teams communicating, many doctors of different levels communicating with the patient, we get feedback like, I'm confused, your doctor said this, the other said this, the other one said this and all that. So, what's going on? I'm so confused. So actually, the way I respond, I always apologize for the miscommunication. I say, and often they actually understand. So I would say, look, I think I must apologize for that. I think I take responsibility, maybe to the answer short, I take responsibility for the miscommunication. So maybe one way to do it is to check back the understanding. You don't need to close the loop, all right? Because communication is not what we give, it's what the other person receives, right? So if it's important, you give the information and then you don't need to close the loop, all right? And maybe if they feel it was condescending, then maybe we need to reflect how the information was given. Yeah, so maybe our tone of voice and that kind of thing, yeah. So that's just, you don't have to agree with me, but that's just how I tend to navigate through this sort of miscommunications and unhappiness from the other party, especially the patient side. Yeah.
Yes, I think I agree with that, Prof. Rafidah. And when we are in doubt, sometimes we just have to say that we do not know, because we cannot know everything, isn't it?
Yeah, that's right. Good.
Okay, the next question is from anonymous attendee. What is your opinion about passive-aggressive behaviors in healthcare communication?
Passive-aggressive. So, yeah, I've heard that term. I think I know what definition is, but maybe I'm quite fuzzy about it. Passive-aggressive means not actually contradicting you, but at the same time refusing to take action or to comply. Is that correct? Is that what you're referring to? So, okay, yeah. So I think, okay, maybe my take on this is that if you're aiming for a culture, it's hard, you can't change people when they don't see anything wrong with what they're doing. So when you want to aim for a culture change, you go for educational interventions and role modeling. And if it's really a problem, I suggest maybe pulling that person aside privately and maybe just asking, maybe you can do the advocacy consent inquiry. I know that whenever we do this, your response is this, my concern is this, I'm curious whether there's something going on or, so I mean, that's one way that you could directly address it. And maybe that's what you should do when you see this sort of behavior that really causes you a lot of grief. All right, okay.
Okay, thank you, Rafidah. There's one message from Dr. Merritt saying, thank you for the great presentation. What you have discussed is certainly something which is important to cultivate in our practice.
Thank you for that. I'm glad you found that helpful, and I hope that, we all can continue to improve ourselves.
Yeah, so in the interest of time, I think I will close our part of the session, and I would like to thank Rafidah again, and I would now like to pass our webinars to our next chairman and speakers. Thank you.
Thank you,
Thank you,
Marzida.
Prof.
Thank you, everyone.
And thank you, Prof. Rafidah, for the clear talk. It gives me a great pleasure on behalf of the Division of Paediatric Neurology, Department of Paediatrics, to introduce my next speaker, Dr. Lim Wei Kang, our lecturer in Paediatric Neurology, who will now go on to talk about improving pediatric acute stroke care. And he'll share us a few pearls of wisdom that he's looked at our UMHealth data. So, Dr. Lim, you can proceed with your talk.
Okay, thank you, Prof. Fong, and good morning, everyone. Let me just share my slide first. Okay, a very good morning to everyone. So in the second half of today's webinar, I'm going to talk about how can we improve the pediatric acute stroke care, possibly in our center or in Malaysia. So time is brain. So what do you mean by that? So we all know that human brain cells rapidly die as the stroke progresses, and the timely recognition and intervention of stroke can certainly improve the outcome. And I mean, we all know that the longer the therapy is delayed, the less chance it will be successful. So time loss in the treatment equals to brain loss. And of course, the time saved in the treatment, we can save more brain cell, and subsequently we can improve the outcome. Okay, so in the pediatric stroke, it's a rare but important pediatric neurological disorder which is associated with significant morbidity and mortality. So in terms of the mortality, it was reported 17%, as high as 17% in the global data. But in the developed countries, which has a better facilities, the mortality, well, it's lower, but it's still significant. It's about 1%. So about 1 to 2 per 100,000 children are affected by stroke annually in developed countries. So if we compare to epilepsy, children with epilepsy, the incidence actually is higher, 50 to 100 per 100,000 of children diagnosed with epilepsy. So even this is rare, but we have to bear in mind that pediatric stroke is certainly an important disease to be recognized because it carries significant morbidity and mortality. However, at the moment, there's no local data available on the pediatric stroke incidence in Malaysia. So let's look at the difference between the adult stroke and pediatric stroke so that we can understand the difficulty in recognizing pediatric stroke better. So as we all know that adult stroke is more common compared to the pediatric stroke. Most of the adult stroke are caused by arterial ischemic stroke in nature. However, in pediatric stroke, half of the stroke is ischemic in nature. The other half comes from a hemorrhagic stroke. And when you see an adult with a sudden onset of focal neurological symptoms, very likely this is caused by a stroke. But in pediatric, a sudden onset of focal neurology symptoms may be caused by other stroke mimickers. For example, hemiplegic migraine, Bell's palsy, thought paralysis after a focal seizure, acute demyelinating disorder, or sometimes, we do see conversion disorder in children coming with a hemiplegia, and also CNS tumor, something that is important to recognize. And for the adult stroke, there are many established acute ischemic stroke protocol with clinically proven effective thrombolysis with TPA and also thrombectomy. However, in the pediatric population, to date, there's no completed trial on the safety and efficacy of thrombolysis with tissue plasminogen activator or thrombectomy in children. So an effective acute stroke care comprises of 3 components: prompt recognition, rapid investigation, and also timely intervention. I will next present a case just to highlight, why these components are important in managing acute stroke. So we saw this case in 2017, the pediatric neurology team in UMC. So it was a 3-year-old girl. She had a acute right upper limb and lower limb weakness at 5 p.m. on the day of presentation. Okay, so 2 days ago, she had some upper respiratory tract infection symptoms and also fever. So mom, didn't really take immediate action, and then she sort of, just observe and see. So the next day morning, the symptoms progressed to right-sided facial weakness and also slurring of speech. And then I think mom felt something is not right, and then she brought the child to visit the primary care outpatient clinic in our center. So the doctor assessed the child and then sent the child for the X-ray of the right upper and lower limb. Although there's no history of trauma, but I think the doctor who assessed the child didn't really think of stroke in the beginning. So of course the X-ray come back as normal, and when the doctor reviewed the scan, the X-ray, and then he quickly recognized that something is not right and it's more than just a routine. The usual weak limb weakness. So he referred the case to the pediatric on-call team. So at 2 p.m., the pediatric on-call team reviewed a right hemiplegia and also right-sided upper motor neuron 7 nerve palsy, and a CT scan was ordered. And at 5 p.m., the CT scan was done after some sort of a logistic issue, because the child was actually sent to emergency department for the scan. So is there anything that we can do better? Now looking back at this case. So when we look at the symptom onset to hospital presentation, it took the caregiver 17 hours to realize something went wrong. And the door to the first neuroimaging evaluation took us 7 hours. So if we count all together, the symptom onset to neuroimaging took a whole day, the 24 hours for us to actually order the first evaluation for these acute stroke symptoms. So I think a prompt recognition of stroke and symptoms is important here, and then we need to act fast. So let's look at the prompt recognition of stroke symptoms. So about 70 to 90% of a pediatric stroke, they present first with acute focal neurological deficits. We can use these mnemonics to help us to recognize, to remember. So what is fast? Fast means, when you spot a facial weakness, arm weakness, speech problem in children or even in adults, it's time for you to call for emergency, time to send a child for further urgent evaluation. But we also have to bear in our minds that there are other symptoms that can present first in pediatric strokes. So 15 to 25% of children present first with focal seizure, about 8 to 10% present with ataxia. Unexplained persistent change in conscious level can also be the first presentation in 17 to 38% of children. 20 to 50% of them can come in first with a severe headache, and some will come with just dizziness. So as you can see, it's not always easy to recognize the first symptoms of a pediatric stroke, but we certainly don't want to miss the acute focal neurological deficit, which is what I mentioned just now. So now let's look at our pediatric stroke data in UMC. So I managed to collect the data for about 21 years, in the past 21 years. So there were 48 patients in our database. So 71% of them actually presented with fast symptoms. So the remaining, they came with a focal seizure, generalized seizure, headache, and also reduced consciousness. But when we put everything together, we can notice that 92% of them actually come in with focal symptoms versus the rest, which are non-focal. So we can actually suggest that for children coming with a focal, acute neurological deficit, we need to have a stroke as a differential diagnosis. So prompt recognition of a stroke is important to help us to manage the acute stroke effectively. So we need to recognize the phase symptoms, the focal neurological deficit, and also the non-focal neurological deficit. So how do we do that? We can create the awareness among the public and also our frontline healthcare providers. We can do the public stroke awareness campaigns in the public, educate the school teachers and students to recognize the stroke symptoms. And like, what am I doing now? I mean, we can actually create awareness among the healthcare professionals, our colleagues, using the hospital CME platform. So now let's continue with the case that I presented just now. So I think 5 p.m. CT scan was done. So this is the Excel cut of the CT brain. As you can see, there's non-specific, left occipital lobe hypodensity. This is actually what was reported by the radiologist. So the radiologist actually suggests a further MRI evaluation because they can't really pinpoint what exactly happened. So I think there was some difficulty in terms of getting the MRI scan done. First of all, I think the on-call team didn't really feel that it's important to get MRI brain straight away, so they sort of waited for next morning to order MRI scan. So at the next morning at 11 a.m. MRI brain with MRA and MRV was actually done. So as you can see, the occipital lobe over the left side still show a hyperintensity on T2 imaging, and furthermore the MRI picked out another lesion in the left globus pallidus. So as you can see, I just want you to appreciate the importance of MRI scan to evaluate a patient with acute focal neurology, because the earlier CT scan didn't really pick up this hyper intense lesion in the globus pallidus, as you can see here. Maybe there's some, but it's tough to recognize. So this shows the value of getting an MRI scan if, let's say, the CT scan was inconclusive. So these are just for some other image sequences of the MRI that can actually highlight the lesion better. So the MRI actually can have this sequence, what we call the diffusion weighted imaging paired with a parent diffusion coefficient. As you can see, the left globus pallidus here showing a restrictive diffusion, which suggests a cytotoxic edema, which is most likely due to the stroke. So there was an acute infarct in the left globus pallidus and also the left occipital lobe with stenosis of a proximal M1 segment of left MCA. So this was actually proven by the MRV later, on the same scan. So what could have been improved? So as you can see now, the door to the stroke diagnosis time by the radio imaging took a whole 25 hours. So, we need to do it a bit faster because the rapid radiological evaluation is very important in managing acute stroke in children. So now let's go back to our UMC data. How about the door to neuroimaging time? This is the first neuroimaging time for our patients over the past 21 years. So unfortunately, there were 16% with no data, no missing data. So as you can see, only a small proportion of patients, about 20% of the patients actually had their first neuroimaging within the first 4.5 hours. Another 10%, have to wait for until the 12, between the 4.5 to 12 hours. And almost, more than half, 54% of children with a stroke actually only had their first neuroimaging done after 12 hours. Oh, so if this sounds very shocking to you, we can compare ourselves to the studies done in our other centers for pediatric patients. So actually multiple studies investigating the time to acute ischemic stroke diagnosis reported a median time to radiological confirmation of diagnosis is between 15 to 24 hours. So actually our result probably is sort of similar to other centers. So the delays was due to delay recognition, delayed access to MRI due to the difficulty in sedation, and also they noticed that after office hour presentation or weekend presentation also tend to have a longer investigating time for the acute stroke. So what's the outcome of a patient in our database? So 23 patients, almost half of them had permanent neural disability at the 2 years follow-up. And out of these 23 patients, only 7 of them, had access to the first neural imaging within the first 12 hours. So 2/3 of them actually had a delay timing in terms of the first neural imaging. So rapid investigation is the second component that can contribute to effective acute stroke care. So the Royal College of Paediatric and Child Health in the UK, actually in their stroke guideline, they recommend CT or CT angiogram within the first hour of ED admission in order to improve the stroke outcome in children. But we also have to consider, the difference between the CT scan and MRI in our setting. Of course, CT scan, is actually provide a quicker access because it has a shorter acquire time compared to the MRI. And we have to consider the need for sedation in young children, and then if let's say the scan will take longer time. There's always a radiation and contrast list in CT scan. There's no such concern in MRI. However, CT scan sometimes can be less sensitive in picking up the changes in a hyperacute stroke. MRI is probably more sensitive in picking up hyperacute stroke, but always, there's a problem with sedation, longer time, and then also it's less accessible in the acute setting. So we come back to our case again. This patient subsequently have CSF done to evaluate what is the etiology of this stroke, and it was found to have varicella zoster virus PCR positive. So the diagnosis for this girl is varicella zoster virus vasculopathy, and this is a form of focal cerebral arteriopathy in children, and this sort of FCA accounts for 35% of acute ischemic stroke in children. So the child was given IV acyclovir and also oral aspirin to prevent further stroke propagation. And fortunately, she achieved a full neurological recovery 6 months from the stroke onset, which is good. So as you can see, the third component of effective acute stroke is a timely intervention, and which can be broadly divided into 2 categories. We will first talk about the first specific treatment. So when we talk about specific treatment, we look at reperfusion therapies in terms of thrombolysis or thrombectomy. To date, there's no robust clinical evidence yet for pediatric patients with stroke. The Royal College of Paediatric and Child Health in UK, actually they suggest, for those who age 8 years and above, we may consider thrombolysis if present within the first 4.5 hours, and with a pediatric NIH stroke scale between 4 to 24 points. And no contraindication. Looking back at our database, I think this is very difficult to achieve because most of the patients they actually present late, and also there's a delay in terms of getting the timely prompt neural imaging. So how about secondary stroke prevention in ischemic stroke? We can use aspirin or heparin, but today there's no consensus as for the duration of this therapy, how long we should continue. But generally, for aspirin therapy, most of the people, they actually use the aspirin to prevent stroke 2 years. It depends on the etiology as well. So of course, we have to treat the underlying diverse cause for pediatric stroke. So for example, hemorrhagic stroke, we need to get our neurosurgical colleague for neurosurgical intervention. For varicella zoster vasculopathy, people use acyclovir plus minus steroid as a treatment for this kind of stroke. We also seeing a few patients with a moya vasculopathy, and for this sort of a patient, surgical bypass will be the treatment of choice. And for a very small proportion, sometimes we do encounter a metabolic stroke, and a specific metabolic treatment is needed with a consultation with our metabolic team in UMC. So, but as a general doctor, we can always make sure we do a proper supportive measures in managing patient with stroke. So we need to ensure normal hydration, normal oxygenation, normal glucose, make sure normal BP, and treat the fever if can, and also make sure if the child has seizure, we treat the seizure properly. So in summary, as you can see, these are the things that is important in managing acute pediatric stroke. So we need to recognize the stroke earlier. We need to increase our awareness. We need to think about stroke when we child present with acute focal neurology. We need to remember the fast symptoms. In terms of the rapid investigation, ideally, CT, CTA within 1 hour of presentation to our emergency department. In the case that the CT scan was inconclusive, please consider MRI scan and remember to include the stroke protocol in order to further investigate the stroke. And we need to intervene timely with a specific and also supportive measure for the pediatric stroke management. So yeah, must be fast to recognize fast and try to remember the neural imaging within first hour of presentation to our emergency department. So, invariably, by managing the acute pediatric stroke effectively, we are also indirectly managing the acute focal neurological deficit in children effectively, because remember, we do have a patient coming with a stroke-like symptoms, but actually they have other underlying medical problems such as acute demyelinating disorder. Sometimes we do have some we call that conversion disorder and things like that. So it's not just about managing stroke, but also try to pick up other acute neurological deficit, neurological problem as well. So I adapted this stroke just now. I enjoyed Prof. Rafidah's talk a lot. So the PACE model, I think we can also apply the PACE model in our management in pediatric stroke. So when we see a child coming to us, the first thing, what can we probe? The child has a unilateral limb weakness. So this should alert us, to the next question. Shall we do something about it? Could it be a stroke? So we challenge ourselves. We want to be curious. Try to find out what is the underlying cause of this acute focal neurology in this child. And then, lastly, we must escalate our management fast. So we need to investigate and also intervene timely. Okay, so just a last message, to the audience. Stroke has got no age limit. It can happen in children, even in babies too. So a prompt identification of stroke and timely intervention can offer the opportunity to improve the pediatric stroke care and subsequently lead to improved stroke outcomes. So I just want to acknowledge Professor Fong and also 3 medical students who spent their 2 months time with us to do their elective posting to help us to compile the data in the stroke database. So Xiaoqing, Qinghui, and also Shuhada. Okay, thank you very much. So with that, I thank you for your attention. Yeah, thank you.
Great talk, Dr. Lim. I think there are just a few questions that the audience would like to ask you. Dr. Lim, can you turn on your video? Okay.
Yes. Okay. Yep.
Yeah. First thing is by Prof. Wan Arifin. It says, can you tell us the etiology of case of stroke in your 20-year study? I think the one correction is not a 20-year study, wasn't it? I mean, this database was from 2015, 2016. So we're looking at over the last 7 years of pediatric strokes that we saw in our caseload. So he's asking, any cases diagnosed with asparaginase associated thrombosis and in patients with congenital prothrombotic risk? Was there anyone that had asparaginase associated thrombosis from our database from 2015?
Yeah. So to be honest, I haven't really looked into the individual etiology in details, but I do know that we have a mixture of hemorrhagic and also acute ischemic strokes. Most of the acute ischemic stroke is caused by viral causes. Some of it actually proven by the CSF. Some actually just came to us with acute stroke after bouts of like a viral illness. But in terms of the asparaginase stroke, as far as I know, we haven't really captured this group of patients in our database, probably because maybe I haven't got this, referral from the oncology side, or we just haven't really picked up this group of patients in our database. But as far as I know, we haven't really have one case of stroke due to this.
And were there patients of congenital prothrombotic risk from the database?
Congenital prothrombotic risk.
I mean, when you look at the risk factors, well, that's something that maybe you can look at.
Yeah. I think for this for our database, so far we haven't really identified anyone with congenital prothrombotic risk. Yeah.
Okay. And Prof. Mary says, are there specific etiologies of pediatric stroke where early diagnosis and intervention will make a crucial difference?
So, of course, there are many factors that can affect the stroke outcomes. Sometimes, depends on the extent of the stroke. But definitely, when we look at those with poor outcome, which is about 23 patients in our database, 1/3 of them actually have a delay, what we call that neuroimaging time. And then the other 2/3, they actually, 1/3 of them actually have sort of a quick access to the neuroimaging, but the other 2/3 actually they don't really access to this neuroimaging timely, within the first 12 hours. So this could be one of the factors. Whether the intervention itself, I think we need to really look at the database and then to decide. But so far, I think I haven't really done the analysis yet to look at this, but I think from what I can tell from the database, the neuroimaging time probably is one of the factor that can actually improve the stroke outcome. Yeah.
Yeah, any specific etiologies, Prof. Mary is saying that you want to pick up early. Anything that you know that you want to pick up early that can make a difference. Here we are trying to get these kids to have early neuroimaging, door to neuroimaging time. We want
yes, definitely
under 1 hour, MRIs, you're considering thrombolysis under 4.5 hours. What are we trying to prevent? What are we trying to pick up? That is what Prof. Mary is asking.
Yeah, so I think, of course, we need to pick up those patients with, hemorrhagic stroke, because, we can actually intervene quickly by getting the right neurosurgical intervention. For those patients who present with acute ischemic stroke, right, if let's say they are more than 8 years old, yeah, if they say it's within the 4.5 hours from the stroke onset, and then we can actually consider acute thrombolysis treatment in this group of children. But however, majority of these children present very late to us, and then they already miss the windows of 4.5 hours. So I think in this group of patients, it's very tough. Yeah.
Well, it's all about trying to set the scene, isn't it? The main reversible causes, as acute dissections, that you may offer, thrombectomy, sort of thing, which we have in overseas had cases like that. They come to us, acute dissection, acute thrombotic events, thrombosis events. Also, those are sometimes considered thrombolysis therapies. So there's a whole host of acute etiologies that actually one can offer early intervention if you pick up early diagnosis. Yeah. In terms, Dr. Hanisa, just want to ask quickly, with the child presented with VZV stroke, did the child have a rash suggestive of varicella zoster stroke?
Yeah, thank you for pointing that out. Actually, this child, when we look back into the history, she had a varicella zoster infection 4 months prior to the stroke presentation. So I think this is likely to be a reactivation of the viruses in the CNS that result into this stroke. Yeah, there was no rash on this patient on presentation.
Okay. Just maybe a quick question by these two anonymous attendees, and I may want to try to answer that quite quickly. Hi, Dr. Wei Kang. If we see a patient of a history of stroke in primary care, what are the things we should monitor and follow up? Let's say they come for other medical follow-ups. Anything you want to just quickly say for any child with a past history of strokes?
Okay, so I think, of course, definitely we have to, make sure in terms of their neural deficit, their limb weakness, their hemiplegia, whether that improve or not. Let's say there's no recovery, we have to make sure we refer this group of patients to our physiotherapy to try to improve their limb function. And not to forget about the psychological impact on these children as well, because some of them actually may feel very stressed and depressed with their neurological deficit. So we need to explore that together with the impact on the parents, the family as a whole. So I think this is something that we should actually look for. And also not to forget, if let's say you see a child coming with a recurrent sort of transient ischemic stroke, transient ischemic attack, recurrent mini strokes, we have to consider a diagnosis of like a Moya vasculopathy. And then this kind of case you have to highlight to us and then refer to us for further investigation.
Yeah, just to add on from what Dr. Lim has said, I think the bottom line is any child with pediatric stroke that you see, first of all, what is the underlying etiology? Yeah, what is the cause of the stroke? And does this underlying etiology predispose to a further higher recurrence risk? I think many times, in our clinic, many patients who are labeled as pediatric strokes have not had even sufficient workup done. Sometimes no one, they didn't even have an MRI scan. Yeah, sort of thing. So I think the bottom line is these children need to be worked up adequately. If they're not seen by a pediatric neurologist or pediatricians who have had adequate workup, really they should be worked up adequately to understand comorbids, recurrence risk. And then you can do the other steps that Dr. Lim has said, psychological support and so forth. But the bottom line is what's the cause of the stroke and what's the recurrence risk? That's my take on it. Finally, a final question. MRI is not readily available outside working hours. Will CT angio be helpful?
Yeah, I think so. Actually, CT brain and CT angio in our setting, I think it should still be the first line to investigate a child with acute focal neurological deficit. It's just that, we have to bear in mind, even though sometimes the CT or CT angio may report normal, but if let's say you are still suspecting the child could have a stroke, we need to try to get an MRI brain to further evaluate. Because in my case that I just presented just now, you can see the difference with the MRI brain, it highlights further brain lesion in the scan. So I think CT scan to me, first line, if let's say it doesn't really show anything, we have to continue to pursue with an MRI brain if let's say we still think this child could have a stroke.
Yeah, so yeah, as what Dr. Lim said, I think any child that we believe have a stroke, they should have CT or CT angio, because then you may pick up dissection, you may pick up certain sort of, vascular abnormalities, sort of thing. So that's really important. So not just a standard CT, you want to increase your yield for any child with a possible stroke. So always add CT angio and of course discuss with pediatric team, sort of thing. So we get this done in a timely fashion. And in the future, we're pushing the bar. We want this sort of patients to have an MRI as soon as possible because, consensus guidelines have stated that, we should be considering thrombolysis, acute therapies in 4.5 years. I think it's not good enough to say that they're coming too late. We should try our best to get door to neuroimaging time down. I think with that, it's 9:02, Dr. Lim. And on behalf of the Faculty of Medicine and the great first webinar, we want to thank all participants for attending this webinar. We hope you found these two talks useful. Remember to claim your MMA points. And with that, I'd like to end this talk today. Thank you, Dr. Lim.
Thanks, everyone.